Start.
A very good afternoon to all of you, those who are watching us live from Oasis Fertility academic activities. Well, today I am going to highlight on the topic that how we should proceed to evaluate a couple with sub fertility. I must say that myself, Dr. Prasanta Kumar Nayak, so I am an endoscopist and fertility consultant from Oasis Fertility Bhubaneswar. Well, let us start with the topic. Uh, I must tell that a person or a couple is diagnosed as to be infertile, or we call them as suffering from infertility, if there is apparent failure to conceive within 1 year of regular and unprotected intercourse. And subfertility is something that when the reproductive efficiency is decreased. In fact, these two terminologies, infertility and subfertility, are used interchangeably because we prefer to use the terminology subfertility rather than infertility because majority of these people have the potential that they can become parents, means she can conceive even if we give some kind of treatments. So hence the proper terminology we should use is soft fertility. But the terminology sterility is used for those who have an absolute inability to conceive. Means at any means she cannot be a mother because of some irreversible factors. And it is called primary soft fertility if she has no previous conception or pregnancy, and we call them as secondary shock fertility if there is at least one previous conception, either it has been resultant into a normal, say, live delivery, or even if it is an abortion. So it has been found that worldwide the incidence of subfertility or infertility is around 10 to 15% in the reproductive age group, and this incidence is increasing day by day also. And if you see the various causes of sterility or subfertility, but let us speak about the sterility. That means those who have a complete inability to have a child, and this can be some irreversible loss of functional gametes, either due to gonorrheal dysgenesis or hematoilia syndrome, or due to some radiotherapy, or even if with post-castration. But absence of reproductive structures in either partner, either it is in Mullerian agenesis or androgen insensitivity syndrome, that leads to sterility. And so in these cases, there are no other management options. We have to opt for either a donor sperm or donor oocyte, or we have to go for a surrogacy or even adoption. If you see the prevalence of infertility, then if we'll consider a couple, then we'll see that the males are responsible up to 35% or even more when we compare to the females. So, and if we consider the infertility in females itself, then the tubal and pelvic pathology is responsible in around 40% of the population of female population suffering from infertility, and 40% is due to ovulatory dysfunctions, means the ovulation is not occurring regularly. Similarly, if we'll come to factors that leads to normal fertility, we have discussed about the factors which leads to infertility, but before that we should know that what are the factors which leads to a normal fertility. This is of course if the female is having a regular and predictable and cyclic ovulation. Usually those women or ladies, if their menstrual cycle is regular, they are supposed to have a ovulation regularly. Similarly, the tubes and that we know is the fallopian tubes, or that should be patent, means the passages through the fallopian tubes should be intact, so that the oocyte after ovulation can enter into the fallopian tube and reach for fertilization in the ampulla. Similarly, from the male side, there should be healthy spermatozoa which should be deposited high in the vagina near or at the time of ovulation. And after this, spermatozoa, while passing through the cervical canal, there should be good capacitation, acrosomal reaction, and acquisition of motility by the spermatozoa so that it can reach up to the ampulla. Then, if it is captured in the cervix, it should be filtered properly, nurtured, and release of spermatozoa by the cervix should occur. And finally, it reaches the fertilization site, that is the ampulla. So arrival in the once it is fertilized, then it comes back to the uterine cavity within 3 to 4 days, and there occurs the implantation. So in the implantation site, that is in the endometrial cavity, there should be a receptive endometrium and a functioning corpusculum. So here in a model, I must tell you that some of the points of how, because this is a model showing the uterus, cross section of the uterus. The uterus is around around 7 to 8 centimeters structure or less, and you can see the both fallopian tubes on both sides, and this is the ovary that is hanging between the uterus and the fallopian tube on both sides. And every cycle, one there occurs ovulation. So one oocyte is released either from the left ovary or the right ovary, and it comes into the peritoneal fluid, and the fimbriae of the tube on both sides, it sucks it inside the tube and it comes into the ampulla. And at the same time, the husband's semen is deposited in the vaginal canal. The sperms, which are highly motile, they get attracted by the chemical nature of the cervical fluid. And here is the area where there occurs capturing, filtering, nurturing, and capacitation of the spermatozoa so that it gets in a momentum. And further, this healthy spermatozoa, motile spermatozoa, they ascend further into the uterine cavity, then they enter into that particular fallopian tube where the oocyte is there. So the fertilization finally occurs inside the ampulla, and once it is fertilized, it stays there for around 3 to 4 days, and then again it goes back to the endometrial cavity. So this is the endometrial lining of the uterine cavity, that is called endometrial cavity. So it gets implanted somewhere in the fundus or any other part of the uterine cavity. So once it's implanted, then blood circulation establishes, the placenta develops, and the fetus grows. So this is the entire mechanism. So if you look at this model, so if all these structures are intact, that means if both the tubes are patent, the ovaries are functioning and releasing a oocyte every cycle, if the endometrial cavity or the uterus is normal and the husband's semen is normal, then all these factors, if it is normal, then she can become pregnant. But any disorder in any of these steps that I have described, that can lead to infertility. So while evaluating a couple with infertility, so we usually evaluate both the male and female partners together. So in the male partner, part of the test we do, and in the female partner, part of the test we do, and part of the sequence and steps of doing all these evaluation that I described. So what I used to tell my patient that whenever they are unable to conceive, usually many of them lose the hope and they don't go for a further evaluation or seek any help from the doctor. But I must say that even if becoming worried and without going to a proper center or a doctor, and the actual problem is not going to solve. So they have to be aware about the availability of these services so that they can have their problem solved immediately. So there is a saying that worry does not empty tomorrow of its sorrow, it empties tomorrow of its strength. Hence, always we should come forward to find the solution, not to become worried and just sit at home. So the evaluation of infertility starts with the basic investigations. As I told, in the male partner, we do a test, a single test, that is the semen analysis. We just collect the husband's semen and we find whether the parameters like the sperm count, motility, morphology, and some few other criteria are absolutely within the normal values or if there is any abnormality. Similarly, for the female, we look for the ovulation, whether she is ovulating regularly or not. We look at the tubal function, whether the fallopian tubes are patent or not, and also other points. So, as such, I must say that while evaluating a couple with infertility, both male and female should be evaluated simultaneously, because if someone will tell that I am right and someone will tell that I am also right, then the problem is not going to be solved. So both have to come forward for this treatment or evaluation. So the indications of evaluation, then when we should start evaluating a couple, whether once they have planned a pregnancy. Usually we tell them that if they have tried, means they are having regular unprotected coitus, means they are not using any kind of contraceptions or barrier or condom, and they have tried for more than 1 year, but still she is unable to become pregnant. That means they should come to us for evaluation. Similarly, if the age of the female is more than 35 years, also they should not wait for 1 year even. They should come even within 6 months or earlier if they feel so. Because once the age of the female crosses 35 years, then usually the fertility potential decreases significantly. So they should not waste their time further, and they should come for evaluation and treatment. If she is having irregular and infrequent menses, because as I told, she is having a regular predictable menstrual cycle, means she is ovulating regularly. If this is not happening, means she is also not having, if the menses are not regular, means she is also not having a regular ovulation. So they should come forward for evaluation. If there is any history of pelvic infection like pelvic inflammatory disease, or there is endometriosis or chocolate cyst, and they should come for evaluation. Similarly, if in the male, if there is some or known or even a suspected poor semen quality, if the suspects or if there is a previous history of anything, then they should come forward. Similarly, there is no obvious problem, but still they're anxious to conceive but unable to get pregnancy. Those people should also come forward. So while a couple come to us for evaluation of their infertility, our first step is usually we take a complete history of them. History means usually we ask their age and both partners, both husband and wife. Usually we ask about their obstetric and marital history, whether she had ever got a pregnancy, or she is married for how many years, and how frequently they have intercourse, and what about their menstrual cycle, what other treatments they have taken outside before coming here, and also if they have any endocrinological disorders like thyroid problem or pituitary or adrenal problem, if he had any history of surgery like any peripheral surgery or surgery on the ovarian cyst and all, and also whether there was any history of pelvic inflammatory disease, sexual transmitted disease, anytime she took a intrauterine contraceptive device or copper T, whether she had features of history, means excessive hair growth in the face and hair loss also, whether she has sudden weight changes, means suddenly she has lost a lot of weight or she had gained a lot of weight, whether she is having milk secretion, that is galactorrhea. And similarly, in the husband also, we ask about whether he had suffered from any genital trauma or surgery in his testes or genital organs. What about his occupation, where he is actually working, and whether he is addicted to any alcohol or history of means habituation of smoking and all. Well, so after the proper history, we go towards the physical examination of the female and male together. So we find the height, weight, BMI, features of secondary sexual characters, which usually tells whether they have that maturity, sexual maturity, so that the gametes are getting synthesized properly or not. So their thyroid status, any signs of androgen excess, and we palpate and examine their abdomen and pelvis to find any tenderness or mass, whether there is in discharge in her cervix, means indicating some kind of infection in the vagina, whether there is an adnexal mass, that means whether the tube and ovaries are healthy or there is some tumor or something over there, whether there is any tenderness, and even if cul-de-sac nodularity, which may suggest some kind of pathology inside the pelvic cavity. And if we'll consider about the indications for testing of ovarian reserve. So one point about ovarian reserve, that usually the ovary consists of some few lakhs of oocytes in the primordial form, but in every cycle either one or two of those primordial oocytes they get recruited, and finally they become Graafian follicle and rupture. So, so these lakhs of follicles are there, means these oocyte primordial follicles are there, but only few of them get ovulated in the entire life of a female. But it has been seen that with the increasing age, these baseline primordial follicles numbers decrease gradually, and after some age, it drastically decreases. So the number of oocytes which gets secreted decreases, and even the quality gets compromised. So this is called as ovarian reserve. So with increasing age of the female, the ovarian reserve is also decreases. So we should go for ovarian reserve test once her age is more than 35. If she has an unexplained infertility regardless of her age, if there is family history of premature menopause, and if there is any previous ovarian surgery or radiotherapy or chemotherapy, if there is history of smoking, and we have demonstrated a poor response to exogenous gonadotropin stimulation even during the treatment. We have given good medications, but still it is not responding. That means there is some compromise in the ovarian reserve. There are various tests for ovarian reserve, that may be a FSH level or estradiol level, even AMH we measure, We measure about some other hormones like inhibin, and we do some kind of tests also to prove that whether her ovarian reserve is good or not. And a very common ovarian reserve test that we usually do in our day-to-day life are the AFC or the antral follicle count. Usually we do a transvaginal sonography on day 2 or day 3 of our menstruation, and then we try to find subcentimetric small follicles which are present peripherally or somewhere around the ovary and in both ovaries. And at least if we find more than 12, that means our antral follicle count is good, her ovarian reserve is good. And there are some tests for ovulation also. That was about ovarian reserve, but whether these oocytes are ovulating or not, that is also means an important question. So there are various tests. It can be indirect tests or direct tests or some conclusive tests which tells that whether she is actually ovulating or not. So the indirect tests are the menstrual history. As I already told, that if a female is menstruating regularly and predictably, that means she is having regular ovulation. It is also associated with metrosmos. That means there is a mid-cycle cramp pain in the lower abdomen when the ovary or the oocyte means the Graafian follicle ruptures. And there can be premenstrual symptoms. There can be primary dysmenorrhea. So these are some of the features indirectly tells yes, she is ovulating. And but we also go for some of the tests like increase in the basal body temperature. There should be for ovulation if it is increasing by 0.5 degree to 1 degree Fahrenheit, just ovulation because of the progesterone. So that there occurs, which indirectly tells that there is chance that she has ovulated. Similarly, if you are testing her cervical fluid also, there occurs loss of horning and the presence of pack effect in the cervical mucus. And we can also see the maturation index shifting in the vaginal cytology from mid-cycle to the second half of the cycle. We can take her endometrial biopsy, which here we can find secretory changes from 21st to 23rd day cycle and onwards. And similarly, ultrasound will show that the Graafian follicle, which was increasing in size, suddenly collapsed, and there is fluid in the PUD fells of the glass, and there is some internal echoes in the Graafian follicle also. Similarly, some of the hormones can be tested like the progesterone, which rises after ovulation. So if the day hormone progesterone is more than 6 nanogram per ml, or on day 20, so if it is more, and it become up to day 21, usually we measure if it is more than 6 nanogram per ml, usually it proves that she has ovulated. Similarly, we also use urine or serum LH level, we also use serum estradiol level. So these are the various hormonal tests which proves. So there is a graph which tells how the basal body temperature is being recorded. So suddenly we'll find that every morning we ask them to measure their temperature, core body temperature, or suddenly we find there is a shift, means there is increase, rise in temperature up to 0.5 degrees Celsius or 0.5 degree Fahrenheit, which means that there is a chance of ovulation. So post-ovulatory we can find this diagnosis. So, and similarly, this is the fawning effect, which is usually found before ovulation. After ovulation, this fawning effect is lost. Similarly, the tacking effect also we find that really this very means you can say liquid cervical fluid becomes gum-like, and there is tacking. That means it is not breaking between the two fingers. And similarly, some of the histopathological study of the endometrium showing secretory changes. So here we can see the ultrasound showing the growth of the Graafian follicle. That means the oocyte is growing up to a level of around 18 to 24 millimeter, and anytime it can rupture. Once it ruptures, it gets collapsed. As you can see, suddenly the round structure becomes collapsed, and we can find fluid in the pouch of Douglas, which means she has ovulated. Similarly, there are some other procedures, as I told, LH test and some other hormonal tests can be done. Even you can demonstrate ovulation by aspirating the fluid in the pouch of the glass, and on the microscope we can see that. Or through the laparoscope also, we can also visualize how the Graafian follicle is getting ruptured, or we can prove the rupture also. And similarly, but the most important thing is the conclusive test of ovulation is always pregnancy. So whatever test we do, we just give a empirical or some direct indirect evidences, but conclusion is only by pregnancy. Well, similarly, the test for tubal patency, as I already told, the fallopian tubes are required to pick the ovary and to carry it inside the uterine cavity. So also for fertilization, the sperm comes all through the way up to the level of ampulla, So after fertilization, it goes back. So always the tube needs to be patent and healthy. So there are some tests which proves that there is some abnormalities in the tubes. It can be HSG, that means hysterosalpingography. It can be some other forms of salpingography. It can be laparoscopy, or with a chrome perturbation we call it diagnostic laparoscopy, sonohysterosalpingography or science test. It can be phalloposcopy. It can be salpingoscopy. It can be transvaginal hydrolaparoscopy or foduloscopy. HSG is a test where usually it is done between day 6 to day 10 of the menstrual cycle, and we use some radiolucent dye, and it is injected into the uterus through the cervical canal. As it goes through the uterine cavity and spills out into the peritoneal cavity through the fimbria, and we take an X-ray, we can see the patency and the dye being coming out. But if there is some block at any point in the tube, we cannot find the spillage of the dye on the side here there is block. So X-ray plate and even during that they can see in the film also, in the screen also, whether it is spilling inside, it is coming out or not. So it also gives an idea that whether the tubes are patent or not. But it should not be done if she is having an active infection or tuberculosis or some other allergies. And here is a real picture of HSG where you can see the uterine cavity being filled with the radiolucent dye, and it is going out and coming through the fallopian tube, and it is now spilled out. Here also it is a patent, it's a normal uterine cavity and tubes, but here we can see there is a fimbrial block, and here also we can see the bilateral fimbrial block, which means hydrosalpinx. It is dilated tubes has been demonstrated here. Bilateral means cornual block. At the beginning of the tube itself, it is blocked. Similarly, if we go to sonohysterosalpingography, that is known as SIS, where the normal saline is pushed through the transcervical Foley's catheter and path of the fluid followed with ultrasound. And here what we can see, there is sour fluid coming out through the fimbria or free fluid in the POD, which means there is tubes are patent. Here we can see through the ultrasound, we can see the fimbrial end sometimes and the fluid collection. So we can, if you see the coming spraying of the water on the same side, we can tell the tubes are patent, else at least one tube is patent. So it is more sensitive than HSG done in a good hand. There is a good that there is no radiation, or it is even non-invasive. So it can be, it has some other advantages that it can give some pathologies inside the uterine cavity also. But the gold standard is the diagnostic laparoscopy with no perturbation test. And if we find the indications of doing a laparoscopy, because it has to be done in the operation theater under anesthesia, so it has some risk and it is expensive also. So for that, we should have some indications like abnormal HSG, symptoms and signs of pelvic diseases. There is chance of endometriosis. There is unexplained infertility if her age is more than 35, or she fails to conceive after 6 months of normal HSG also. That means a kind of sub fertility which is not being treated by any other method. So in the laparoscopy, we can very well directly can visualize whether there is a hydrosalpinx. You can see there is fluid inside the tubes. That means the tubes are swelled off, and this might not be patent. So this can be treated. Either the block can be removed, or if it is very much pathological, we can remove the tube itself so that it will not affect the pregnancy rate and all. So there are some direct and detailed visualization through laparoscopy. So it is the gold standard technique for defining the tubal patency. It avoids corneal spasm, which is a site means a false positive cases comes in case of HSG, because patient is not anesthetized. Pain can cause spasm, so that will think that the tubes are blocked. But in the laparoscopy, because he's under anesthesia, so all these false positive or negative things are being avoided. It is both diagnostic and at the same time we can also treat if there is a cyst, there is a block or any other pathology. But the disadvantage of laparoscopy, it is invasive, it is costly, it is surgical and anesthesia is required. But there is no information about uterine cavity unless we combine it with hysteroscopy. So we do diagnostic hysterolaparoscopy in the same sitting. But it is done only after explosion of male factor infertility and ovulatory dysfunction, especially if we are giving the treatment for normal means a natural method, or we by methods at least up to the level of IUI with that. But if you are going for a higher order ART, even with a male factor abnormality, we can do, because we need to maintain the uterine cavity or the tubes more healthier, because we have alternatives to get. sperm or some other methods. We can also retrieve the male means good sperm patient techniques. So other tubal patency tests are we can go for laparoscopy techniques also, or hysteroscopic means endoscopy also. And so these are the various tests where the small flexible scopes goes inside the tubal cavities and find out the pathology, and we can treat them. So various tests for uterine factors are also there. This is all about tubes and ovary, but what about the uterus? Uterus can have tumors like fibroid, the endometrial cavity can be distorted, it can have some congenital anomalies, it can have some intrauterine cavitary problems. So to come across all those problems, either we can do HSG, where the uterine cavity abnormality can be diagnosed, the TBS and SIS, sonography, saline infusion salpingography, where we can push the water inside, and we also can find intrauterine lesions like polyps and some mucosal fibroids. Even the hysteroscopy can tell details of the endometrium and the endometrial cavity. The laparoscopy can tell about the tubes, the ovaries, and all around the uterus. And here we can see the HSG. It is a normal uterine cavity with spillage on both sides. Here we can see a small space occupying lesion, some space defect. That means can be a fibroid or some mucosal fibroid inside the uterine cavity. You can see the honeycomb appearance. That means there is some chance of synechia, means intrauterine is there. So here we can see a banana separate uterine cavity, which means it is a unicornuate or bicornuate. Means unicornuate, mostly the kind of uterus. And here we can see this is a bicornuate uterus, or it can be a septate uterus, where both the endometrial cavity are separated by the septum, but here it is widely apart, means it is a bicornuate uterus. Similarly, in the SIS, that is saline infusion sonography or sonosalpingography, where we can see the endometrial triple line very well, and even we can see a polyp inside the endometrial cavity because water fills here, so the polyps come out, means it becomes more visible. We can see smaller ones also. Even the septum can be diagnosed. So many diagnostic things we have. Similarly, through hysteroscope and laparoscopy, through hysteroscope we can see intrauterine, means that uterine cavity, if there is some mucosal fibroid or there is multiple polyps are there, whether there is a septum is there, we can treat them in the same sitting. And here it is, these are the adhesions, synechia, and this is the bicornuate uterus with a gap between them. Two corners of the uterus are well separated, not a single cavity. Here also we can see that unicornuate uterus with only one side tube is attached, the other side tube is well apart from it. So now coming to the test for cervical factors, as I told, the cervix is the part where there occurs filtration, capacitation, and the sperm gets its momentum. So there are so many tests like the postcoital test. Nowadays it is not being done, but these are some of the conventional tests that can be used. But usually what we do, we go for taking the semen sample of intercourse from the cervix, and we just see it under the microscope whether the criteria of movement, the vitality, morphology are well mentioned or not. And other than that, some cervical tests like immunological factors can also be tested, like Cramer's test, immunobid test, or mixed agglutination reaction test. So these are some of the tests are available, but may not be that much effective because cervical factors are just suspected, but we cannot prove most of the time. And similarly, immunological tests by immunobid reaction and all can be done. Now coming to unexplained infertility, that means, as I told, that there are factors responsible for infertility, either tube or the ovary or the uterus or the husband's semen can be analyzed or can be evaluated and treated. But there are still people suffer from infertility even if everything is normal. So those are the conditions what we call as unexplained infertility. So unexplained infertility means no cause is there. So the criteria should be normal semenogram, objective evidence of ovulation is there, bilateral patent tubes are there, normal uterine cavity is there, no other cause of infertility like endocrinopathy should be there. So finally we call them unexplained infertility. So to diagnose unexplained infertility, usually we should go for diagnostic laparoscopy and should exclude whether there is endometriosis or adhesion and all, which are usually not found early conditions through ultrasound even. Well, so these are the steps of evaluation of a female who is suffering from infertility. But we have also methods to diagnose the factors responsible for male infertility. So the most important one, what we do is we take a proper history, we do analyze their semen, and we do a physical examination. If the semen analysis is abnormal, we do a hormonal testing, we do radiographic evaluation, ultrasound and all, and if required, we go for invasive and surgical testing even. So the most and the commonest consistent evaluation for females is the semen analysis. So we usually ask them about their method of collection, and at least 2 to 5 days of abstinence is required. It should be in the lavatory or near to lavatory, should reach within 30 minutes so that the quality and the criteria of the semen is being maintained. And after that, it is being analyzed. Here, we just try to find whether the criteria of normal female semen parameters are fulfilled or not. Like the volume should be at least 1.5 ml. The total sperm count should be 39 million, and the sperm concentration should be at least 15 million per ml. And the progressive motility should be 32% or at least 30% as per latest guidelines. Or the morphology should be 4%, means out of all these spermatozoa seen, at least 4% of them should have normal morphology or characteristic feature of a normal spermatozoa. And all other factors like the pH and the presence of fructose zinc and should also be evaluated, but more important things I just highlighted. So if you find any form of abnormality in the semen, we just give them the type of nomenclature like normospermia for normal parameters, aspermia for absence of semen, azoospermia for absence of sperm in semen, hypospermia for low sperm semen volume, oligospermia for low sperm count, asthenospermia for poor sperm motility, leukocytospermia for increased WBC, necrospermia for spermatozoa with dead spermatozoa, teratospermia for increased morphological defective sperms, and we call means if there is any three variables, then we call them weighty or oligoasthenoteratospermia. So these are the terminologies being coined to different kind of semen abnormalities. So we do go for their physical examination to find the BMI, thyroid status, breast status, distribution, size of scrotum, testis. Epididymis should be palpated, varicocele should be excluded, and even we should do a rectal examination to find out whether the prostate is hypertrophic or any problems in the seminal vesicle or ejaculatory duct is dilated. So other than that, we go for the hormonal assays of the males like the thyroid, the FSH, LH, prolactin, and testosterone, and we find whether these belong to normal cutoff levels or they are abnormal. So imaging like ultrasound is being done for the scrotum to find out the volume of the testis, is the presence of hydrocele or testicular cancer, the features are present. We do Doppler to find out varicocele, we do transrectal ultrasound which indicate any features of azoospermia, low volume ejaculate if present, then we should also go for this cross and all. A vasogram can also be done for ejaculatory duct obstruction, and also venography is done to confirmation of the varicocele. Other than that, genetic evaluation can also be done, especially if you find small testes, very poor parameters in the semen and hormonal abnormalities. They may suffer from Klinefelter syndrome, Y chromosome microdeletions, or any like a gene mutation and all. So all these things are being performed if we suspect any advanced problem in the male partner. So testicular biopsy can also be done to differentiate between testicular insufficiency and the genital tract obstruction in azoospermia or severe oligoasthenoteratospermia, as I already described, with normal testicular volume. And therapeutic semen sperm retrieval in case of non-obstetric azoospermia for cryopreservation can also be done. And what we suggest that if you are doing a testicular biopsy and they are planning for pregnancy, better if we get good sperms or spermatozoa in the sample, we should freeze them so that it can be used during the process of ICSI. So well, so this is all about the evaluation of male and female infertility. I must end with a quote. That is, the longer you wait for something, the more you appreciate it when you get it. Because anything worth having is definitely worth it. Well, friends, if anyone wish to listen all these topics or this topic at least, either in Hindi or Odia, they can message me so that I can have different sessions or recorded sessions which we can upload to our Facebook or other social medias also. So thanks for watching. Hope you all have understood something from my lecture. Well, if anyone is interested, they can ask me a few questions also. Hello, thank you. Okay, there is a question, how to investigate, no, infertile couple. Is it the question? It's being displayed. If anyone is ready with any question, they can ask. Yeah, I'm back in the screen, I think. I'm back in the screen. Yes, Bidu, I'm back in the screen. Is there any question, but I didn't find any question. Okay, while it is being displayed in the screen, how do I investigate an infertile couple? Is this a question? Please answer. Okay, so this was all about the topic what I described. So if you wish to know how do I investigate an infertile couple, that I have already told, that usually depending on the criteria whether they wish to have a pregnancy immediately, then we usually call them to our clinic and take a proper history and examine their physical things, physical parameters. Then we try to find whether the male or the female is having any abnormality in either form. In all the cases, we usually go for a female semen analysis for the male partner, and for the females, depending on their problems, we just investigate whether she is ovulating or not, whether the tubes are patent or not, or she is having any other problems inside her uterus, in the abdomen or in the pelvis. So accordingly, we do tests like starting from HSG or laparoscopy, hysteroscopy, ultrasound, all these things. So already I have described step by step that for individual factor, what test we need to do. So once we do all these tests, of course we should go for only required tests. Not all the tests for all the people is required. So as per their history and examination, we decide what the test actually we need to do for them. Then only we do perform those tests, and if you find any abnormality in any hair, then we go for treatment accordingly, targeted treatment. So any other question? So someone is asking what tests are done to check fertility. So check fertility or check their means to evaluate infertility. I think it's similar. To check their fertility status, you mean to say. Usually, if someone is have not planned pregnancy, we don't go to check her fertility or his fertility. Unless they are concerned, they are doing some pre-pregnancy plan, means counseling or treatment. Else, if they are planning and they are unable to conceive, so it is checking a fertility is equivalent to checking means evaluating infertility. So the same things we do. So we do some all those examination history, individual test as I told, semen analysis, even in the ovarian reserves if at all required. So all those tests step by step we do. Blood test directly is not required to test infertility. Yes, if you do some specific blood test, like we measure their AMH level, we measure their FSH and LH level for the females, even their prolactin and thyroid levels. If these are abnormal, they may have some contribution towards infertility. Like this, they give some indirect evidence that there can be anovulation, there can be some ovarian reserve problem, so that we can treat them accordingly. Someone is asking what does primary subfertility means. Subfertility and infertility are the terminologies that are interchangeably being used. Means they are similar. Primary means she has not been conceived any time in her life. That means she has never been pregnant. That is primary subfertility. Someone is asking, do infertile women have periods? So that's an interesting question. So these are common beliefs. that all the infertile females means there is no menses means there is no chance of pregnancy. On the other hand, also if a woman is menstruating means she will always have the potential to have pregnancy. So for to have menses or periods, you need the female need to have a good uterus and a good hormonal axis. That means the hypothalamus, pituitary, and ovarian axis. So all these hormones would need to be normal. So that is not required always. If she has a problem in her tubes, it's such, if there's tubal blocks, but she is menstruating, she cannot be pregnant. Just a simple example I'm telling. So there are so many conditions, even if she is having periods, but she can be infertile. But if a regular, predictable menstruation means she is ovulating. That is correct. Any other question? How common is sub fertility? It is common nowadays. As I told, up to 15% of the population is suffering. Nowadays, the prevalence is also increasing day by day. So, because of the lifestyle, the time or the age by which they plan their pregnancy, usually advanced age, you can say. So, all these are responsible. Yes. Okay. So, if the questions are finished, then we can stop the live session. Thank you all of you once again for watching us live, and see you soon with another topic based on infertility mostly. And thank you very much.